Intraventricular hemorrhage is the most common type of neonatal intracranial hemorrhage. It occurs mainly in preterm infantis, less than 32 weeks of gestation. Approximately 30% of premature infants less than 1.5 kg have intraventricular hemorrhage. The incidence decreases with advancing gestational age and is influenced by certain perinatal risk factors and also obstetric cares. We classify risk factors into intravascular, vascular, and extravascular. From intravascular factors, impaired cerebral autoregulation, fluctuating cerebral blood flow related to fluctuating arterial blood pressure, increased cerebral blood flow, such as due to hypercarbia, excess volume expansion, and increased cerebral venous pressure, might be from pneumothorax, asphyxial heart failure, hypotension and reperfusion, coagulation abnormalities, and those who have stars shows factors that can often be prevented or alleviated with meticulous intensive care. When we see the vascular factors, germinal matrix is a highly vascular structure with poor capillary support and is present in less than 35 weeks and is critical factor in pathogenesis of IVH. Germinal matrix capillaries are very vulnerable to hypoxic ischemic injury. The arterial development is, at this stage, there is acute transition from large vessels to a capillary network without gradual herborization around germinal matrix. The other is extravascular factors. Preterm infants have increased fibrinolytic activity, poor vascular support in cerebral tissue, and increased risk of hypoxia, hypercarbia, and acidosis due to immature respiratory system. When we see the clinical presentation, 90% of IVH occurs in the first 3 days after birth. It can present as a catastrophic, saltatory, and asymptomatic one. 25 to 50% of IVH is asymptomatic, just is discovered on ultrasound as screening ultrasound, and also foreign hematocrit or failure of hematocrit to rise with transfusion should cause concern. The other is gradual deterioration in neurologic status, which might be subtle abnormalities in level of consciousness, movement, tone, breathing, and eye position or movement. The worst one is catastrophic. Acute IVH with bulging fontanelle, split sutures, change in level of consciousness, pupillary and cranial nerve abnormalities, decerebrate posturing, and often with rapid decrease in blood pressure and hematocrit and also seizure. Regarding grading of IVH, IVH is graded into 4. Grade 1 is bleeding confined to periventricular area, only germinal matrix area. Grade 2 is intraventricular bleeding. In this case, 10 to 50% of ventricular area on sagittal view is occupied by blood. Grade 3 is intraventricular bleeding, which occupies or which takes more than 50% of ventricular area or when it distends the ventricle. Grade 4 is intraparenchymal ecodensity in addition to intraventricular hemorrhage, which represents periventricular hemorrhage in addition to intraventricular one. So if there is intraventricular and extraventricular, we call it grade 4. In general, outcomes with IVH grade 1 or 2 are similar to infantis without IVH. When we see the mechanisms of brain injury from intraventricular hemorrhage, it includes preceding hypoxic ischemic injury that predispose the neonate to IVH, increased intracranial pressure with massive IVH which decreases cerebral perfusion, also destruction of germinal matrix by blood, and injury to the periventricular white matter due to infarction or due to damage from blood products such as potassium or other vasoactive factors can cause brain injury. In addition, post-hemorrhagic hydrocephalus due to impaired absorption of CSF by blood can cause brain injury. Always we should have to focus on the prevention of IVH in preterm babies. Prevention includes prenatal preventive mechanisms and postnatal. During prenatal period, prevention of prematurity, giving corticosteroids or antenatal glucocorticoids to accelerate lung maturity and decrease IVH incidence, and also optimal obstetric management is very important. During postnatal period, skilled resuscitation to avoid hypoxia and hypercarbia, circulatory support to avoid hypotension and the fluctuating arterial blood pressure, and the correction of coagulation abnormalities is very important in prevention of IVH. The other is about management. Other than early diagnosis and careful supportive care, including correction of coagulopathies, circulatory and respiratory support, there is no cure or therapy for IVH. Just the management is supportive. For progressive ventricular dilation or post-hemorrhagic hydrocephalus, the essential point is early recognition. Head circumference does not increase until after there has been considerable ventricular dilation. So measuring head circumference is not adequate. So we should have to have periodic ultrasound screening. Therefore, serial head ultrasound examination in infants with IVH greater than or equal to greater 2 is important. Some cases of ventricular dilation will respond to serial lumbar puncture, acetazolamide or carbonic anhydrase inhibitor, which decreases CSF production, or other diuretics can be given. Persistent progressive ventricular dilation requires a ventricular reservoir or ventriculoperitoneal shunt by neurosurgeon. Let's see the schedule for cranial ultrasounds for preterm infantis. We should have to do cranial ultrasound on the first day for those preterm infantis who have perinatal asphyxia and in utero drug exposure. On day 3, if there are unstable clinical course. And for all preterm infantis less than 32 weeks of pregnancy, we should have to do transfontanal brain ultrasound on day 7. Then, if any IVH, ultrasound in 1 week for early detection of hydrocephalus, and the subsequent examination depends on clinical course. On the first screening, if there is no IVH, repeat ultrasound at age 4 to 6 weeks for detection of cystic periventricular echomalacia. So for all preterm infantis less than 32 weeks of pregnancy or gestation, do transfontanal brain ultrasound on the 7th day of life, and if there is no IVH on the 7th day, repeat at 4 to 6 weeks. When we see the prognosis, grade 1 and grade 2 IVH have a good prognosis. Mortality rates are based on the grade. Grade 1 have 3% mortality rate, grade 2 is around 8%, grade 3 is around 22%, and grade 4 is around 36% in one large studies. In grade 4 bleeds, significant area of cerebral tissue might be lost, forming porencephalic cyst. The incidence of hydrocephalus was approximately 35%, and the higher the IVH grade, the greater the risk. Finally, in preterm babies, if there are periventricular white matter lesion, the possible differentials include periventricular hemorrhagic infarction and the periventricular echomalacia. We should have to differentiate between them. In the case of periventricular hemorrhagic infarction, this is usually asymmetric and grossly hemorrhagic. It presents in first few days of life. Whereas periventricular echomalacia, usually it's bilateral. It's not it is symmetric and small. It presents several days to weeks after birth. Both have association with abnormal neurologic outcomes, especially cerebral palsy later in life. Thank you for watching.